Hello, welcome to Casual Conversations. Very happy to have you all here today. I'm at my first conference, intermingling with people without masks in Atlanta, Georgia. So it's really great to be back. And there's a whole bunch of new people in the field that have graduated in the last 2 years. So it's exciting to see old friends and meet new people that are starting in the brain injury field. I'm excited to have with me 3 lovely people from the UK. First, I want to introduce Hope, who is our UK director. Hi, Hope.
Hi, Katherine.
How are you today?
Yeah, I'm good, thank you. It's good to be here.
Great to have you. And Hope and I will be interviewing Annmarie and Joss. So welcome to our program.
Hi, Katherine. Hi, Hope. Thank you for having us.
Hi, Hope. Hi, Katherine.
So I just got muted, so I'm back. So let's start at the beginning. Let's start with Joss. And where you born? Where did you grow up? And tell us a little bit about your pre-university life.
I'm from the southeast coast of England, and I kind of spent my formative years on the sunny Sunshine Coast in the UK, on the beach, and the old school fairground rides down there. So I grew up down there and lived around there until I went to university in Bath, down in the West Country in the UK, where I did sociology and social policy in Bath, which is a great city to go to and an amazing place to go to university. And I spent 4 years at university, with a year on placement working for the Metropolitan Police, actually, which was a really interesting placement to have. I worked in the research and survey unit, supporting the Met to think about how it could use different research methodology and design to engage with officers across the police force, but also the communities that it was trying to reach and engage with. So I spent a year in London doing that, having a great time in the middle of my university.
Was that something that you had thought as a direction to go in, or was that a random place?
I don't think I'd ever thought about going into the police force. I think I'd thought of using kind of the research area of my degree and thinking about how I could connect with communities in different ways and understand their needs, kind of complex communities, and understand their needs and think about how we can make changes, tangible, practical changes to the way we deliver services, which improved support and information available to those communities. So the Met Police bit was a bit left field, but it was a great experience and gave me a really good experience of working in kind of a really big organisation that was trying to work on across a number of different fronts as well.
Well, that's fascinating. Annmarie, what about you? Where did you grow up, and what connections to science or to working with people did you have?
So I grew up not that far from where Joss grew up, but not on the coast, a bit further inland in a place called Crawley, which is a very unglamorous part of the world. But my parents were a teacher and a neuropsychologist, so I was not hugely imaginative in my choice of career. But I did see my dad really enjoying his work as I was growing up. And so I thought, right, that looks like a good career. And he used to take us to the units he worked on, and we used to meet people. And so I think that's probably where my interest started. And then I moved to London to go to university, and I went to UCL, which was an amazing place to study psychology. They have a huge neurosciences department there. And it was really there I got to work with Tim Shallis and do my undergraduate research that my interest really started growing. And on leaving UCL, I was lucky enough to get a job at the Royal Hospital for Neurodisability, working with people with very severe brain injuries, right at the other end of the spectrum. And I really enjoyed that role. It was very difficult work, very challenging work, but really, really interesting. And from there, I went on to clinical training, which I did at Royal Holloway. And again, every place in the UK, when you do your training, you have to do lots of different placements, child placements, adult placements. Every placement I went on, I tried to find a neuro angle. And since qualifying, I've always worked in brain injury.
Can you explain? I'm at a legal conference and I keep trying to explain for lawyers that are trying to see for someone that is injured, the trajectory that they should be looking at Australia, New Zealand, the UK, where you have a socialized medical system and how that is of value to research. Could you explain a little bit for our non-UK how the socialized medicine allows tracking of brain injury over time?
So I mean, I've only ever worked in this system, so obviously I don't know what the alternative is, but the advantage that I see is that everybody gets access to the same level of healthcare, regardless of where you live or, in the most part, or what you can afford. And so, and it's a centralized system. So, we can get information from any health service. So I might have a patient who originally had their brain injury in Glasgow, but I can get that information from them because we have information sharing agreements. So I think there's just that consistency. And also I can immediately understand if I have a patient and they've been to a unit that I don't work in, I still know what they will have been delivered, what healthcare they will have received. And again, I think that's really helpful in terms of planning research and getting it done.
Joss, do you have any thoughts on that, on how the UK is different?
I would say, I just wanted to kind of add to that around some of the populations that we work with through our work in the foundation. So men and women in prison, homeless populations, domestic abuse survivors. I think whilst they do have access to healthcare, they often have poorer health outcomes. And I think specifically around brain injury, there is a limited recognition, identification of brain injury for those people, and therefore they do get missed by the system. I think that there is great care at a trauma level, at a kind of acute stage. I think as we move through, and for people who have milder brain injuries or multiple mild brain injuries, they often get missed. So I think the healthcare system is great, but I don't think we're meeting the needs of everybody. Yeah.
And I think one of the key things there was, although it's available to all, actually to navigate it requires, it's a really complex system, and to navigate it, you need someone who can advocate for you. So if you don't have a family member or a friend that can do that, often these people with milder brain injuries who live in, difficult contexts find it really hard to access services.
Hope, do you have any thoughts on that from your perspective of the research?
I mean, yeah, I was going to say, I think Joss and Annmarie have summed it up really well. And I've not actually been in the NHS in our healthcare services for a couple of years now, so I'm a bit out of touch with what happens there. But I think from a research perspective, there's like the usual administrative challenges in getting hold of data and sharing data, and the ethics around when it's appropriate to do that for research purposes, but at least the data is linked and is generally in the same format, which does help. So yeah, no, I don't have much to add.
And in this country, there's several different large studies and, national, trying to raise money for a national registry. And, we're still, I feel like, trying to figure out how to connect the systems. And then we have this huge barrier of you have to be able to pay for them, or you have to have no resources at all. So you either can pay for it. And in this country, a heart attack or cancer or a brain injury bankrupts a family. It's just kind of you go into financial duress and you have to declare bankruptcy. They just announced in this country that a few of the largest credit bureaus are now going to not count medical. I forgot a bill 4 years ago. I missed a $120 bill from my hospital, and it went to collections, but I was in the middle of chemo, and it's literally on my records for 7 years as affecting my credit. So there's this whole financial key that if you are not managing your financial billing at the same time you're going through a crisis, you're, penalized. Now you all have weights there, but from a research standpoint, you do have a trajectory of being able to follow someone pretty well and see outcomes.
I mean, it is complicated because people will jump between different systems, and also they may end up under social care, which is not quite the same as the NHS. And so, it's not entirely straightforward. But yeah, I don't know, Joss, if you...
No, I was just going to say, and sometimes our systems don't talk to each other, so we don't necessarily have data that kind of flows quite so easily between some of the different systems in terms of the criminal justice system through into health. We're getting better and we're trying to get better, but I think, definitely around brain injury, kind of the fundamental issue is identification, and it kind of not being picked up, and therefore you're trying to kind of unpick data sets and understand kind of people's journey when you don't really necessarily have a complete picture. And I think brain injury is one of those things that we're not particularly good at recognizing when people are engaging with some of our public services, like the criminal justice system, like housing and homelessness support and work and pensions.
Hence the work that the Disabilities Trust is working on. So do you want to explain a little bit about the trust and how you got there, how you connected?
Yeah, sure. So the Disabilities Trust has been around for over 40 years, and we are an organisation that supports people with brain injury and autism and learning disabilities and physical disabilities. And we have got neurorehabilitation services, we've got a hospital, we've got supported living services all across England, Wales and Scotland. So we've got a kind of rich history and clinical expertise within the organisation in terms of supporting people with brain injury. And over 10 years ago now, the organisation set up the foundation, which is the team that Annmarie and I are in. And the foundation was set up to think about how we could use our experience and our expertise to meet the needs or understand better the needs of populations who may never come into contact with our care services. So populations like those engaging in the criminal justice system, homeless populations, domestic abuse survivors. So for the last 10 years, we've been working in forensic settings. We've worked in prisons all over England and Wales. And within that, we've developed different tools and practical solutions to thinking about how the criminal justice system can better meet the needs of men and women with a brain injury, and kind of trying to think about real tangible ways that we can support improved outcomes for those men and women, but also for those that are working within the system themselves to feel more confident about engaging and supporting people with a brain injury. So we developed a brain injury screening index tool, which is a screening tool which is freely available, and it's clinically validated tool to screen for a history indicative of a brain injury. It's 11 question screening tool that allows you to understand if a brain injury is likely to have happened and make a kind of an assessment of the severity of that injury. And we've used that tool in our research in prisons to understand and estimate the prevalence of brain injury within those populations. So we did some research in HMP Leeds and in prison in Leeds, which is a male prison up in the north of England, and we identified in there that 47% of the population there had a history indicative of a brain injury. So, roughly 50%. More recently, we did some work in HMP Drake Hall, which is a female prison in Stafford. And there we didn't necessarily go in to estimate prevalence, but we did find that kind of 64% of the women there had a history of brain injury.
How did that compare to the men?
So the men was just under half, and obviously the women were kind of reaching two-thirds. But what we did find in Drake Hall,
higher number of women than men with brain injury in prison.
Yeah.
And did the screening look at neurological other pieces of their history, like neurodivergency? Mostly about brain injury?
No, it's a tool for brain injury. So the tool itself doesn't can bring in anything around autism or other learning disabilities. But Annmarie clinically supervises our link worker service, where we do look at other tools.
Yeah, I mean, the busy does ask about other neurodiverse diagnoses. So it does ask people, but it's all based on self-reports.
Right.
And
how did you find it? Was there a sense that the women in the prison were, not happy, but wanted to be involved in the research? Like, was there a sort of a sense that they were part of something, and that something had been big that had been missed?
Yeah, absolutely. I think the women that we spoke to had at no point in the community, nor at any point in their engagement in the criminal justice system, had they had any support for their brain injury. And often it had been misattributed to other conditions, or they had just felt that, often they said to us, they just felt they were going mad, or they were losing their mind, or that they were putting it down to other things. And for some women, they felt it was a relief to understand that actually the things that they were experiencing were a brain injury, and that there were things that they could do now that could actually help them navigate those impairments and the impacts that they were feeling. I think we're a long way from really understanding what this means in the context of the UK. It's an emerging area, but I think definitely from our work in Drake Hall, we feel that there is something there that we need to kind of understand more about.
And was it a surprise to you that the number of women in prison with brain injury would be higher than the number of men?
I think potentially naively, we hadn't estimated or considered that the number of women, because 62% of those women that we worked with had sustained their brain injury through domestic abuse. And that wasn't something that we had considered. And I'm sure for many people that is kind of screamingly obvious when you think about the trauma and the violence that survivors of domestic abuse experience. But it wasn't something that we had considered. And I think it's something that, since we understood that more from our work at Drake Hall, we've been really committed to kind of finding out more about and kind of working with others and survivors themselves to think about what that means in a UK context.
Do you have more you want to add to that, Hope or Annmarie?
I mean, I think I was just going to say that I think one of the issues is that these women often themselves don't identify the link. They don't present to hospital. They don't present to their GP. And so that link is never really made. And so I think that sort of public awareness that survivors of domestic abuse may have a brain injury isn't really there. And this study has been really helpful, I think, in raising the profile of that issue and just shining a spotlight on it and showing us that it's something that's really important to look into. And it brings us back to the issue we started talking about at the beginning, which is that although we have a health service available to everyone, not everybody accesses it for a wide range of reasons. And how can we understand better, how we can make the health service more accessible to these women who really need the service?
Your thoughts, Hope?
Yeah, I was just wondering if you could talk perhaps a little bit more about the link worker interventions that you introduced, I think on the back of that research in Drake Hall, and how effective they were, and what the strategy was and how you designed that.
I'll leave that one to you, Annmarie.
That's fine. So I joined the service I joined the Disabilities Trust in October. So I've not been around for ages, but I clinically supervise the brain injury link workers. So I can talk a little bit about the service that we deliver. So we're currently delivering it to 2 prisons in South Wales, Cardiff and Swansea. And we screen the men with the busy to identify brain injury. I have to say most of them have had multiple brain injuries. They're not people who've just had one brain injury, they've had many, usually through road traffic accidents or assaults. And we then have an intervention which is quite protocol driven. It's quite, I think Joss described it earlier as sort of light touch, but it's very powerful. And what we do is we usually start with some education about what a brain injury is, because often it's a revelation to the people that having had a head injury might result in some difficulties. So that's where we start, and they find that really empowering. And what they say is that no one has ever really explained this to them. And I think Joss spoke about it a little bit earlier, that often people worry that they're going mad. These are very internal experiences that they're having, so they might not even be sharing it with other people. They might be trying to mask it. And other people might just be experiencing them as a bit disorganized or annoying or distant. So that's where we start. And the aim really is to help them to understand what the issues are and what the difficulties are, so that they can then explain to others why they're experiencing what they're experiencing and what they need support with. And then we will move on to thinking about, are there any compensatory strategies that we can use? Can they learn to use reminders or notebooks or all sorts of different things? Now, obviously, we're quite limited in the prison. So use of mobile phones isn't allowed, no kind of electronic devices. So that does kind of, restrict what we can do. But the feedback that we get and what the research has shown is that this really makes a big difference to the people who receive this intervention. We've looked at things like the number of acts that they're on. And an act is basically that when someone's placed on a particular treatment plan, care treatment plan, because they're struggling within the prison environment. And we know that those reduce significantly after our intervention. We also look at the number of incidents that occur. So that might be conflict between the person in prison and a prison officer, and those also reduce significantly after the person's had the brain injury link worker intervention. So although it's not hugely complex, it's very powerful. And I think that's what's interesting, and that's what's really driven us to pursue this also with the women in prison.
So
I don't know if you want to add anything.
No, any more that you want to add, because it's so important, and it's such important work, and hopefully we can figure out across countries, how we can work with people in prisons, and then work with people before they get to the prison level, and then go back to the educational, and then in 20 years we can say there are fewer people in prison because we've helped before they got there.
Yeah, I think that earliest point in the criminal justice system, or even before, is a kind of real good, kind of tricky nut to crack, but something that we really need to think about where we are ensuring that people who have a brain injury are being identified, so that actually that pathway to prison isn't an inevitable one, that actually there's off ramps that can be made. I think one thing to say about the link worker intervention and our experience with that is that actually by providing training and awareness to people who work across the prison establishment, actually you can, and supporting them to think about kind of some really simple adaptations that they can make when they're interacting or engaging with somebody with a brain injury, there can be quite a significant change in how people engage within the prison regime and engage with rehabilitation programs. And I think it also, we find, gives people working in those environments the confidence and understanding to be able to do something different. I think often the men and women we work with are considered as really challenging, or people have tried everything and nothing works. And we often find that they're in segregation because they're kicking off on the wings. And I think by giving people that work in prisons the understanding and knowledge so that actually they could see that behaviour through a brain injury lens, you actually allow the opportunity for a more positive interaction between them.
We recently had an article in the New York Times, and it highlighted the work of probably even 20 different people and organizations in the United States working in the domestic violence, TBI space, from work in Arizona, actually work in Canada. So basically and most of those people have been on this show before. It was a really long article, and it was in the Sunday magazine. So it's one reason why it was. But in the comment section, there were two comments that really stuck out. A woman who for several decades had run a domestic violence shelter and just said, it wasn't until I read this article that I realized that the maybe I saw as obstinate, difficult to work with, not making appointments, not following up, this behavior that I saw in the residents that we actually punished because they weren't working with the system was actually brain injury, and that was, I thought, a very, very honest statement. The other one was a judge who wrote to me and said, after decades as a judge on the bench, he never considered brain injury when women came up to him and receiving restraining orders against their partners. And may have seemed a little off, or I don't know, they seem like they're on drugs, or that there was a judgment of those people that didn't include brain injury and how that would look. So literally just this one article has these two career people going, oh, so that it's surprising is not so surprising when you look at people that have been in this space for decades.
Yeah.
And I think that's,
sorry, go on, Annmarie.
I was just saying, I think that's why it's so important that we educate people around why they have the difficulties that they have, so that they can advocate for themselves, so that they can say to that judge, these are the difficulties that I experience and this is the support that I need. Because often these people don't have people around them to do it for them. So it's really important that we support them to do it.
I was just going to add that I think that experience of the kind of penny drop moment where people suddenly realize that what they've been working with, it could be down to brain injury. I mean, I used to work in drug and alcohol services myself, and since having come to work within the brain injury field, I reflect back on some of the people that I worked with, thinking actually potentially some of that behavior, that disengagement, the cognitive issues that they were experiencing could well be down to brain injury. And I think that's why kind of the work that we're just about to kind of kick off is so important, because we are engaging with domestic abuse services. So we've got 5 domestic abuse services across the UK who are working with us to understand and estimate the prevalence of brain injury for survivors, domestic abuse survivors in the community. And we've pulled together this research with survivors themselves. So they've been involved in the development and the design, and really kind of challenged and stretched us to think differently about how we've designed the research, the areas that we want to understand, and the kind of really critical areas that would make a difference to them. And I think it's been because we recognize that from our side, we're brain injury experts. We're not domestic abuse experts, and the only way that we're going to do this in a coherent and positive way that will make a change and not feel like we're doing something to people, we want to do it with people, is if we actually ensure that we're working with survivors and domestic abuse organisations right from the start. So that's kind of been our real drive as we've developed this next stage.
Yeah, I did just want to underline that you said that women with the lived experience had been part of the initial design. What are we looking for? How we're going to look for it, and throughout that process. And I see that also in NECA's work in Canada and Angela Colantano, and including survivors in what's important to you is such part of the empowering process. So just want to honor that you do that.
Yeah, and it was such a great experience for us to kind of do that as part of the research, the building of the research protocol, and kind of supporting us to take that through our ethical review processes as well. And I think it will mean that actually what the findings will hopefully really kind of point to kind of positive change, because they come from that experience of somebody who's been there, accessed those services, engaged with the criminal justice system, whether as a kind of witness or victim, or through kind of offending behavior, and kind of really help us pin down those real kind of points of opportunity to do something different.
Yeah, I think that strikes in the well, why should we help those women? Because they're just going to go back anyway. You're sort of doubly blamed in that part to have this research be connected. One of the issues I know that sometimes women worry about is if they're identified, then they'll lose custody of their children. Was that a concern in building out the study?
Yeah. And also how perpetrators might use a brain injury as, or weaponize that label in criminal or family court proceedings. So I think what we're trying to do is, as we undertake the research, we're asking questions around people's engagement with family courts, around engagement with the police force, both as victims and witnesses, and through offending behaviour themselves. But we're also engaging with barristers this side in the UK to think about actually how those findings are landed and how we make sure that there aren't any perverse outcomes from findings around brain injury. And I think that's something that we're really sensitive to. And the survivors themselves were really keen that we made sure we were cognizant of as we went into this.
Are there concerns that Hope, from your perspective, with children, or how the information can be used?
I think a key part of any development of healthcare in prison and social care in prison, particularly for women in prison, has to be family focused and promoting relationships with women and their children and family time in prisons and things. And it's something that's really difficult when women are often, because we have fewer women's estates, they're often kept very far away from their families, and family interventions and things are quite difficult. So there are unique challenges that face women in prison that don't necessarily face men in the same way, which is probably, part of that lived experience work that you're doing as well, and part of that narrative for women that are in prison. Yeah, so I think there's a lot to consider there, I suppose. Yeah, and I don't necessarily have a question around that for you, Joss, but it's just important to think about.
It's important to acknowledge that not having the brain injury identified also isn't helpful for these women, because in that circumstance their behavior could be misinterpreted and, you know, viewed as disruptive, or, you know, they're not engaging with the court proceedings. So I think, you know, you have to make sure that we consider both sides of this. We absolutely need to make sure that we don't cause any harm, but equally we need to acknowledge that the current situation isn't great either, and that's why we're doing this work.
And I was speaking to a criminal court barrister last week who was saying that actually she viewed this as kind of a real positive if we were able to help the court system understand that actually the individual in front of them, either that individual there as a victim or a witness, or as somebody who is considering their own offending behavior, that if they had a brain injury, that would help explain some of their behavior in court, help support their engagement and their consideration and the jury's consideration of the witness statements they were given. And I think that was something that survivors said to us that they really wanted us to understand, was actually how brain injury is impacting on survivors being considered as unreliable witnesses and prosecutions being discontinued due to the impairments from a brain injury. And if actually an understanding of brain injury would support and ensure that the survivor got the right and appropriate support to engage properly, that ensured more successful prosecutions, then I think it's a really positive thing.
And I've seen a video, and we had her on, I think, a brain injury task force from Scotland, about a training for police to say that, and it was a cartoon, but it was so great about, you know, that if you're interviewing someone after a traumatic event, they may remember the clock or the cat walking by, but they don't have a sense of time, or where it isn't going to be a linear, like at 3 o'clock, this happened, at 3:15, this happened, what you would expect, but that the outcome with trauma is that it is, you know, sort of a mishmash of sensory that either was remembered or not remembered. And I think sort of in the same brain injury is that, you know, that there could be a more, you know, just because your narrative doesn't follow how one is expecting to, doesn't mean it's not valid and that you're making it up.
Yeah, I think we have been doing a lot of work around training of professionals, and we have a training program that's now available across the prison and probation service in England. So all 60,000 prison and probation professionals can have access to this training. And within there, we've got a film called Invisible Me that I'm very proud, because it won 2 awards at the Cannes Film Festival. So I'm very proud to have, I don't have the Golden Dolphins, but we have the award was given to the film, and it's called Invisible Me. And if you Google it with Invisible Me, the Disabilities Trust, you can find it on YouTube. But it's a great film that really, the idea was these are time poor professionals who we need to engage in this subject right from the off. So it's a 2-minute call to action film which says to you why brain injury matters in your professional space in the criminal justice system, and hopefully continues their engagement through 3 short 20-minute modules. So if you can, and I think Hopes has just put it up on the chat for the film, so have a look at that. Yeah, let me know whether you think the Cannes Film Festival Awards were worthwhile.
Well, in sort of this last phase, what would you like to share with the audience about if future things that are coming up, positions available, reports? How would you like to interact with, you know, the international community on this?
I think that we're really excited by this next stage of the research, and my new researcher is starting with us in the beginning of April. And it's so great that we're going to be getting this underway, and we're going to have the opportunity to understanding the prevalence or an estimate of the prevalence in the UK and the impacts that that may have for the individual, but also their interactions and engagements with services. I think what we're really keen to do as we move through this research process is make sure that it's grounded in the experiences of survivors themselves, but also that we're really clear about the context to which these findings will go into, whether that's the criminal justice system or domestic abuse services, and that we're making sure that it's helpful. So I think if there's any survivors that want to kind of engage with us and understand more about the work that we're doing, we'd love to kind of hear from you. If there's anybody out there that kind of wants to know more about the work that we're doing in the Disabilities Trust, so we've been engaging with colleagues in Ohio who are doing some great work over their work around domestic abuse and their chat tool and their care package. And we're thinking about how we can helpfully support each other in terms of our research. So if anybody has any research that they're going on that we think that we could mutually support each other with, we're really kind of open to that. We see this as, it's not an issue that is particular or peculiar to the UK, clearly by the people that are here. And I think that there's great work going on, such as the work in Ohio, that we'd love to kind of learn from. We don't want to reinvent the wheel. I think, yeah.
Absolutely. I mean, that it's just, there's so, I mean, I think with COVID, there's some more money coming into this space, but anytime we can work on amplifying each other's work. I mean, I think I have to say, as opposed to the youth sports space, the domestic violence TBI space is the most inclusive, community of people that I've ever been a part of. So, and I think the optimism and the passion of the people in this space really, inspire so many people to keep going with the work when it is sometimes overwhelming.
Yeah. We've definitely found that with the services that we've engaged with in the UK, who have just been so keen to think about how they can support this, and so keen to think about how they can help us recruit participants and ensure that those participants are kind of safe as they're engaging in the research process, and then other professionals across the system who are helping us think about the next stage and the findings and the recommendations. So I think we have been really pleased with the amount of support we've received. And as I said before, it's kind of critical to the success of this, because we can't do it on our own.
There are some positions still available for.
We have a successful candidate for the researcher post, but I look at the DT website because I have a couple of positions in my team that I'm looking to recruit to. So if anybody is interested in the work that we're doing, either in the domestic abuse space or kind of in prisons or in other populations, then yeah, take a look and send through your CV.
Hope, I'm sure you've been popping into the chat. If you want to just see any questions you want to pull out of the chat while I give Annmarie a chance to, any other things that you'd like to add?
I think Joss did a great summary. I think for me, this is just a really good starting point for us to understand more about TBI in survivors of domestic abuse. And for me as a clinician, it's critical in thinking about, okay, so what do we do next? How can we support these women? And we can't do that until we fully understand what it is that we need to work with. So I feel very lucky to be part of this research, and I'm really looking forward to seeing how it all pans out.
Thank you. Hope, are there questions that you want to pull out of the chat before we go to the open format?
Oh, sorry, Katherine.
Go ahead.
I didn't mean to interrupt. There's a question from Deneen, who raises a really important point and says that actually missing from a lot of the conversations are the voices of Black and Indigenous and people of colour. So what are your thoughts in order to help women from those groups and engage a wider group of women? And how do we include professionals that look like the people who need to access the care?
I think that is an issue for all aspects of healthcare and not just this one. I think we all have to actively engage with making sure that the people that we work with in terms of the survivors of domestic abuse or the people that work in prisons are an accurate representation of the population, and making sure that we are as inclusive as possible. I think that employing people who, as you say, look like the people that come from different groups is really important. And it's something that I definitely am working on in my role in the NHS. And I think Disabilities Trust is also very committed to that. I think it's an area that we need to improve. I think it's a journey. But yes, very, very important, and definitely something that we are holding in mind.
And as Hope's reading through, if you have a question, just raise your hand and we can alternate between questions in humans and questions in humans that have put questions in chats. Any other questions?
There's a lot of really good comments and thoughts in the chat, and there is an email address in there for somebody who's a survivor that works in prisons at the moment, so definitely note that down, Joss.
And I'll copy the chat for you, Joss and Annmarie. So if there's something that you don't want to say on the screen, I mean, if you don't want to say in person and you put it in the chat, I can copy the chat and send to both of them later so that they'll have that.
I just have seen a question there about projects in the community outside prison, and I think it's important to kind of say that this next phase of our research is solely based in the community. So what we want to understand is for survivors who don't necessarily engage with the criminal justice system or aren't in prison, to understand the prevalence and the impacts and the support that they're experiencing. So I think it would be great once we have those findings that we can kind of share those with you all, so that, you know, hopefully it'll be helpful for your work in South Africa from your comment as well.
Nat's always good for a question.
Thank you. This is a great presentation. I think something that we can encourage every entity to move forward with whenever we encounter any person is assume competency. Assume competency first, and then meet someone where they live and embrace them in their competency, however that presents. Because a difference due to a disability is just like an accent or another language. We meet people where they live, and we find success when we come together in that way. Thank you.
I heard an interesting, or someone said an interesting thing, that there's a lot of talk about, you know, people or populations or groups being hard to reach. And this person said, those people aren't hard to reach. We, as in the health services, are hard to access. And I think that's a really important thing to hold in mind. We need to take steps to, as you say, meet these people where they live. And I really hope we can kind of hold on to that thought as we go through this work.
And is your tool in other languages?
Don't think it is it?
No, but we have been approached by various different people who want to kind of translate it themselves. So I think, again, if anybody wants to kind of do that, that's fine. The tool, which is the Brain Injury Screening Index, is free for anybody to access. You just have to go onto our website, the Disabilities Trust, and you can get access to it. You have to give us just your email address and we can send that to you. So please feel free to do.
I have a question which I don't know if anybody has an answer to, but I'm here in Atlanta at a conference for lawyers working in brain injury and looking at children and adults in accidents and seeing their outcome. And I've been thinking about that, and I wonder about the intergenerational effect of having parents with brain injury on a child and on the family, and how certain conditions, sort of pass generational to generational. And if you'd seen any research where you're starting to ask some of those questions, like did either of your parents have a brain injury, or how it affects between generations and the family system.
I mean, I can't bring to mind research on that, although I'm sure there is someone out there researching it. In my other role, I work in the NHS in the community, and I work with lots of people with brain injuries who are parents. And I regularly have conversations about the impact of that on their children. And I think particularly when people have those more subtle brain injuries, but have difficulties with executive functioning, which affects their ability to, manage complex social situations, it has a huge impact on parenting. We all know without a brain injury, parenting can take you to your limits. And so if you don't have those same levels of control, it's incredibly difficult. And I can only think that has to have an impact on, the younger generations. What the extent of that is, I don't know, and I don't know from a research point of view, but definitely it's something I observe in my clinical practice.
Yeah, and that brain injury really it's not just a one-time event. It's a it goes over time, and it affects the whole family of somebody having to care for that person, or even if they're in school, just find those services, and just the amount of time and energy it takes for a family to support that person. And if you don't have that support, then you end up, I think, in some of these really poor outcomes where you don't have people interceding between you and some conflict, or some poor outcome financially, or some poor business decision in that space. So any other questions, Hope, or
So Lisa has a question in the chat. She asks, how is this differentiated from a personality disorder or mental health disorder, and when it's brain injury? And will this prophesize as justification for behaviour or personality, and that the brain is not plastic to change? So I don't know if you actually want to unmic Lisa and ask the question, because I don't know if I fully understand all of the parts you want to know.
I mean, I can start with the first part of that, which is, I think what the question was is, how do we know that these symptoms aren't actually the result of a mental health issue or personality issues? It's really tough. That is really difficult. I mean, I guess the first starting point is identifying that the person has had a brain injury, and whether that be through self-report initially, but also through exploring their medical records. I think that with experience, I've worked in this area for longer than I care to say, you do start to learn some subtle differences, and you get to feel for what a brain injury is, or what might be more related to personality issues. But I think that's something we need to be very mindful of, and that's certainly something when we're working in the prisons that we have to be careful of. A lot of these people will have additional mental health problems, and we have to ask ourselves, what are we treating? Are we treating the brain injury? Are we treating mental health issues? And so with the brain injury link workers, we'll often think about, okay, well, what is the really presenting problem here? And if it is the mental health issue, then that's what needs to be treated first, and then after that we can think about the brain injury. But it's difficult. I don't think there's a simple answer to that. I wish there was.
what would you like to see, looking back in a decade? What would you really like to see happen in the next decade in the UK?
Who wants to go first?
Besides a huge pile of money to
Yeah, I was going to say.
You go first, Joss, and I'll follow on.
Okay. All right. I think I would like to see, I mean, obviously we'd like to see that less women were experiencing domestic abuse and therefore less people were sustaining brain injury. But in the absence of being able to kind of do that, I think what we'd like to see is that all services where people go to get help, get support, engage with kind of public services have an awareness or a curiosity around brain injury that supports people to reconsider the individual's behavior and reconsider their interaction and engagement with it. And that we have a system wherein people can access support and rehabilitation over their life course that isn't time limited, that supports an individual at a point of crisis or a point of kind of immediate care after an injury, that actually we recognize that people's needs and rehabilitation needs ebb and flow over a lifetime, and we need to ensure that people have a support mechanism there to help them consider the impacts of their brain injury as their context changes and their needs change, I think.
And I think, we're coming at this research from the end of working with organisations that work with people with domestic abuse, but I would like to see brain injury services being much more aware of this issue and asking the right questions. And I'd also like to see community brain injury services, linking in with Joss's point, that are accessible to everyone, that everybody can access, not just those people who have people advocating for them. And if I could have one more thing, I would like to see clinical neuropsychology more representative of the people that we work with.
I was just thinking with the connection with the legal system, are you seeing, barristers I think are what we would call a judge, right? A barrister's a judge.
No.
Barristers
Like a legal counsel, I suppose. Is that what you?
Okay, more like a lawyer.
Yeah,
Are
like
you,
a lawyer. Yeah.
Are you seeing from that program that those in the justice and law system that they're like absorbing the material and coming back and like is it taking hold in that space?
I think that the criminal justice system in the UK has taken kind of huge steps forward in terms of appreciating and understanding the impact of brain injury on the people that they're engaging with. I think we've got a long way to go from the discussion and the acceptance of the link between brain injury and offending, and then seeing that change in practice. We're really pleased that we've got some basic brain injury awareness training out there, but we need to really kind of think about how we're embedding that. And I think, the government here in the UK has just committed to doing a brain injury strategy, which will be cross-departmental, including the criminal justice system, but also including domestic abuse survivors and neurorehabilitation provision. And I think that that's a really great opportunity for those that work in the brain injury community, people with living or lived experience of brain injury, to kind of come together and really kind of tell the government what it is we need that makes a change. And I think, those that are working on the kind of program of the government's ABI strategy are in listening mode at the moment. And I think it's important that we come together and take that opportunity. So I think, progress has been made, but we're not quite there yet.
I think it would be really interesting to talk to have somebody on the show from that side of the world who has gone through the training and said, wow, and then the last 6 months I'm seeing it this way. So if you see if there are people, and it goes for anyone on the show, if there are people, suggestions that you have on people you'd like to come on the show and have this format, do let me know. Glenda, you had your hand up.
Oh, sorry. Yes, I did. Sorry. Just trying to work out how to unmute myself. Yes, I wanted to ask Annmarie and Joss, in terms of here in the UK, are you working with any of the educational institutions? I did put a comment in the chat. Say, for example, the nurse training schools, the prison training institutions and the social work institutions. And the only reason why I'm asking is I worked previously in ABI rehab and from a mental health nursing background, and I had absolutely no training or awareness of brain injury until I took that job. So I had to educate myself on the job. I was a clinical nurse manager there. And I found it very interesting that we had a lot of nurses who were working in that environment who were mental health nurse trained or learning disability trained, but there wasn't any sort of training that we'd received during our training on ABI. So I'm wondering whether that's moved forward now in terms of disseminating that information through educational institutions.
I know a little bit about that. Same You, which is a brain injury organization, and I met them at Queen Square, but it was, oh gosh, she's the main dragon mother in Game of Thrones. Who's the actress?
Oh, I know who you mean.
Mother of Dragons. So Mother of Dragons, I can't pull her name out of my head right now. Her mother, after 3 they weren't brain injuries, but until I'm at a conference and I'm very tired. Yeah, Amelia Clark. Yeah, her mother put together Same You after her 3 episodes, and they were trying to reach out to nursing. I know that was one of the things they were trying to do.
Yeah, they funded lots of training in Queen Square. Actually, she raised lots of funding for that, and I know that's happened over the last 12 months. I mean, I think, sort of reflecting on Glenda's question, I suspect that, I don't know, but I suspect that nursing, mental health nursing, still has very little brain injury education in it. I know that even in clinical psychology training in the UK, there's very limited neuropsychology training, and that people actually specialise later. So I think that's definitely a continued area for development. But I guess the work that we've done has mainly focused on the criminal justice system, and everybody there should have access to the training that Joss has been talking about.
We also considered whether actually it should be part of the induction training, but I think here in the UK, definitely for kind of prison staff, the induction training is so squeezed and so tight. If we were able to get anything in, it might only be a short bit. And I think, that's still a good thing for us to do, but I think we need to make sure that there is something in place that provides that kind of broader, fuller information. And that's kind of why we've taken the route that we have. We have got a tool called the BINI, which is the Brain Injury Needs Indicator, which is a tool which was specifically designed for those working in social care to understand the needs and impacts of a brain injury from their position. And I know that there is some work that's just starting in the UK around considering how to better support social workers through their training and ensuring that there's training and information in place. So again, I think it's getting better, but we're not there yet.
Well, that's awesome. I just want to jump down. Paul, are you interacting with the prison system in Canada?
No, not directly. Obviously, we're aware of the various work that's been done looking at brain injury in the prison system and the intersection in women with intimate partner violence, but haven't done any work directly on it.
We're going to have, hopefully many of you can come to New York September 22nd, 23rd, 24th, the New Yorker Hotel, where it's going to be NABIS, IBIA, pediatric, legal, all together. And we're going to have a Pink Concussions somehow meeting for everybody to meet. So it'd be great to sort of somehow do this is what's happening in my country and connect the resources up. So I really appreciate Annmarie and Joss and Hope for representing so well the UK today. Thank you. And thank you for everyone joining us. And I should, by the weekend, have the last couple of weeks up for Casual Conversations. Next week is the 31st. We're going to have a break, and as I will be on an airplane. And we will then have a full session in April, and I'll send out those reporters. We're going to have a full cast of talks in April, and I'll send out who will be our guests. So thank you, everyone, and great work in the UK. And hopefully you can figure it all out. We can replicate it in our countries because it's so needed. So thank you both.
Thank you.
Thank you, Katherine. Thank you, everyone.
Take care. Thank you for your question, Glenda and Nat. Thanks, Paul. Bye, everyone. Stay safe. Take care.
Bye.